Hey, good morning, everybody. I can't see the screen. If someone just who's online could tell me that you can hear us. We're good. Okay. So welcome to Grand Rounds, and we're very happy to have Dr. Sean Barbour with us. This has been a long time in the making. I think that we have an in-person round with Sean. So to tell you a bit about him, he is an associate professor and nephrologist with UBC Division of Nephrology in Vancouver, the medical lead and chair of the BC Renal Glomerulonephritis Committee and GN Registry. And that doesn't really do it justice, because really after he finished his GN fellowship and MSc in Toronto, he came back to Vancouver 2013, I guess. So it's been about 10 years, but he has built an incredible clinical program to provide GN care to all of BC, and has also established a really impressive research infrastructure. And through that, his focus is on clinical trials, health outcomes and health services delivery, research in GN. And more recently, as we know, he's been focused on risk stratification, particularly in IgA nephropathy. We use the International IgA Nephropathy Prediction Tool. It's been validated now in multiple places. And through that work, he is now chair of the International IgA Nephropathy Network Research Group, and is doing lots of great stuff in that space. I think he's going to tell us about some of it today. He has a whole bunch of grants and everything, and he's very, very impressive. And, so we're delighted to have you here, Sean, and looking forward to it.
Thanks, Mark. Yeah, thanks everyone. Thank you for the invitation to come. It's kind of exciting to do in-person rounds again, even if it is a hybrid format. It's the same thing for us. We've been doing virtual rounds for so long. It's nice to actually move back. So I'm from UBC, and today I'm going to talk about personalized risk management in IgA nephropathy. I guess I kind of have to face this way a little bit. And what I'm going to focus on is actually some of the collaboration that I've had in the past through UBC and University of Ottawa. So these are my disclosures. So we're going to start off with a case presentation. This is probably pretty similar to a case you might have here. It's a 34-year-old South Asian female. We have a very large South Asian representation in the Lower Mainland in Vancouver. She was born in Canada. She has a past medical history of hypertension for the last 10 years, which is obviously a little bit unusual in someone who's 34 and is on sort of submaximal ramipril. She was found by her family doctor to have proteinuria of 2.5 grams per day and some on and off microscopic hematuria with a GFR of 75. This is what prompted a referral to nephrology. And her blood pressure was 132/84. She has a kidney biopsy done that shows IgA nephropathy. There were 22 glomeruli, 2 were globally sclerosed, and there was 20% interstitial fibrosis. So there was a little bit of scarring consistent with the disease onset. It's probably been there for quite a few years and may have started at the time of her hypertension. There was diffuse mesangial hypercellularity, as well as 2 small crescents and 2 areas of endocapillary hypercellularity. So her MEST-C score would have been M1, E1, S1, T0, and C1. So the first question she asks after you see her in clinic after her biopsy is, I've never heard of this disease. I can barely pronounce it. How common is IgA nephropathy? It turns out actually, so British Columbia is relatively ideally suited to study glomerular diseases at the population level. Obviously, as you know, healthcare in Canada is very provincially based, so each province is its own sort of standalone healthcare system. The universal healthcare system aspect, hopefully, to some degree, reduces barriers to being diagnosed with the kidney disease. And also, fortunately, Canadians don't move around that much. So, once they're in a province, they tend to stay in a province. Emigration out of provinces is pretty low. Also in British Columbia, what's unique is that throughout the entire province, so there's about 5.4 million people in the province, all kidney biopsies are read in one center in Vancouver. So they get shipped from the entire province to one nephropathology center. There's 4 pathologists, actually now 5, but it gives you one place to go if you wanted to actually capture all biopsies done across the province. So what we've done is we've created a system by which we can capture and then link data for patients with glomerular disease. And so we have a provincial renal database called PROMIS. It's run by BC Renal. And we've developed a system where every patient who gets a biopsy gets registered and promised. And then there's, from that point onwards, automatic data linkages that occur to capture things like dialysis, lab data, vital statistics data. Patients that are seen in BC Renal funded clinics, which I guess would be here like your CKD type clinics, would have some medication data entry. But really, there's then an opportunity to link that data with, for research purposes, to other administrative data sets that may themselves not have been originally designed for research, but you can use them secondarily for research purposes. So we've linked it to the discharge abstract database to capture hospital admissions, to the cancer database, to medication dispensation. So what's different in BC is that all medications for all patients are covered in PharmaNet. There's no age-based cutoff like there might be in Ontario. To physician-based billing data or to other databases. And the sum total of all that linkage is what we refer to as the BCGN registry. It's not actually a standalone registry, but it's more like a distributed model where it's done through database linkages. And from that point onwards, we were able to capture all patients in the province with glomerular disease as of January 2000 to study glomerular disease at the population level in British Columbia. And so getting back to the question about incidence, I started to wonder, as we were getting this data, I started to wonder, well, how could we use this data to study the incidence of glomerular disease in BC? And not only that, is the incidence uniform across the province, or are there areas of particularly high incidence for certain glomerular disease? Like, are these things clustering together in a geographic format? So the more you start to think about this analysis, the more you realize it's actually not very straightforward to do this kind of analysis. And I went down a deep rabbit hole wondering how you could actually analyze this data with the primary question of looking at geographic clustering of disease. And so I started reading papers that have done this in other areas, including in perhaps violent crime data, looking at peripheral vascular disease from Australia. There was actually a very good paper done on multiple sclerosis in Manitoba. And there was also a paper from Ireland on spatial temporal clustering of anti-GBM antibody disease. So, at the time, Adira was head of ISN, and Adira is our division head. And so because, she's obviously very well known, but was particularly well known at this time, and there were lots of nephrologists and trainees around the world continuously coming to Vancouver, wanting to work with Adira for a few weeks. And she was so busy, she kind of always pawned these responsibilities off to other people. Like, oh, you should meet this guy from Mexico or this guy from France. And then she goes, oh, you should really meet this guy from Ireland. He's really good. He likes the same things you do. He's into statistics. He's into methodology. And so at first I was like, yeah, I'll meet him sometime. And then finally I sit down and I meet this guy. And so I'm sitting in my office and we're sitting there. I have this stack of papers on my desk at the exact same time. And I'm like, the wheels start to turn in my head and the cobwebs start to clear. I'm like, wait a minute. Are you like this Mark Kenny that was the first author on this anti-GBM spatial clustering paper from Ireland? And it turns out he was. And then I realized at that point, okay, this is a guy I can work with. We have the same interest in methodology. He did a postdoc at UBC from 2017 to 2020. And then unfortunately he came to work here. But that aside, we've done quite a bit of collaboration together, and I'll try to highlight some of those collaborations actually in this talk. So coming back to the incidence question. So again, this is a paper I published with Mark, and we used the biopsy data from 2000 to 2012, and there were 824 cases of IgA nephropathy, adults with IgA nephropathy in BC during that time. As I said, it's a multi-ethnic province, right? So the ethnic distribution is pretty much as you would expect. Just about 60% of patients are either Asian or South Asian. Kidney function at the time of biopsy is quite a bit lower than what you might expect from other research cohorts or clinical trials. And I think that reflects what goes on in the real world compared to what actually occurs in focused research cohorts. And as a result of that, the risk of progression to ESKD was quite high, right? This is not a time to event, it's just the number of patients. But 28% of patients experienced ESKD in that time frame, which put IgA nephropathy in a similar ballpark as ANCA vasculitis and FSGS. So, there's very different outcomes that occur, I think, when you study all cases in a region as opposed to select cases that might get into a research cohort. In terms of the incidence of disease in the province, it came out at 1.79 per 100,000 person years. And so you wonder, well, how does that compare to other regions in the world? I think we can usually consider countries in Asia to be at higher risk, higher incidence of IgA nephropathy, and that number is higher than what's been reported in countries like Singapore, but lower than what's been reported in, for example, Japan. And Japan has a screening program for children, which probably drives up their incidence rate. But so it puts BC at a pretty high incidence of IgA nephropathy compared to worldwide. The question is the incidence uniform? So this is a heat map that shows the geographic regions of British Columbia, and the incident rate ratio is shown on the color scheme. And if all regions in the province had the same incidence of disease, everything should be white. But that's not what we found. We found certain regions that tended to have disproportionately higher incidence of IgA nephropathy, with incident rates hitting up around even up to twofold higher than what you would expect. And 68% of that geographic variability could be accounted for by 4 distinct clusters of IgA nephropathy in the province. And you might say, okay, well, that's interesting, but what's the ethnic distribution in the background population, and does that explain this particular clustering? And indeed, when we looked at the background proportion of people in those regions that were South Asian or East Asian, this was associated with an increased incidence of IgA nephropathy, but we were able to adjust the incident rate ratio for the population demographics, including population level, age, sex, and ethnicity, and there was no change whatsoever to the increased incidence noted in those clusters. So these were not identifiable based on population demographics. Now, that wasn't true for all glomerular disease. I just put down a comparison here for lupus nephritis. So lupus nephritis also had a clustering of incident disease, but when you adjusted for the population demographics, that effect entirely went away. So that was explained by the background, younger age, more women, higher Asian background might contribute to the clustering of lupus, but not necessarily to IgA nephropathy. So what this suggests is that in a multi-ethnic province, the overall incidence, as I said, is around 1.79, which is quite high compared to other Asian countries. We did see higher incidence in regions with higher East Asian and South Asian ethnicity, which is consistent with what we see in Asian countries, and therefore suggests a degree of genetic factors driving the incidence of disease, as opposed to environmental factors that might be specific to East or South Asian countries. But the incidence was not uniform, and there were geographic clusters of disease, but these could not be identified based on simple population demographics. And I think this is part of what justifies the mandatory central reporting of glomerular disease at a population level, because if you want to be able to identify regions that have a disproportionately higher incidence of disease, or that have incidence changing over time, you have to have a central mechanism of capturing these cases. And I think this is really important when it comes to allocating healthcare resources to these groups of patients that are need disproportionately higher level of care. It's hard to advocate for that if you can't actually describe what the incidence of disease is. And that's probably going to become more important as newer and more expensive therapies come out for IgA nephropathy. You kind of have to understand exactly what the burden of disease might be. So coming back to the case, the next question we have, okay, is all right, so we've described the disease, we've described the incidence. She now says, well, what's my prognosis? Like, what's the chances that my kidney function actually starts to decline? And this raises the question of how do we risk stratify patients with IgA nephropathy? There are, in terms of risk factors, there are multiple risk factors that have been described, at least on their own, including the MESC histology scores, demographics like age, sex, and ethnicity, clinical variables like kidney function, proteinuria, and blood pressure. And there's just a multitude of other risk factors that have been described that maybe haven't quite been as validated. But the question is how do you actually combine these together at the individual patient level so that you can get patient level risk stratification? So the ideal risk prediction framework, I mean, this has been discussed for years and years, right? So the ideal risk prediction framework is, number one, it has to involve predictor variables that you actually have access to, right? If you have to measure something like galactose deficient IgA1 molecules and you don't have a clinically validated assay for that, there's no point really clinically in including it in a risk prediction framework. It has to be applicable in multiple ethnic groups, given the ethnic variability that we know exists in IgA nephropathy and that we've already demonstrated, for example, in British Columbia. And it has to be applied at clinically relevant time points. If you have to wait a long time to observe things like proteinuria, then it defeats the purpose of risk stratification. So to address this, this issue, the International IgA Nephropathy Network Research Group put together a large collaboration of data sets from around the world. These were data sets of adults from North and South America, Europe, and Asia. And the goal here was to derive an externally validated prediction tool that could be used at the time of biopsy. So there was a derivation cohort of roughly 2,700 patients and a validation cohort of 1,100 patients. So the goal here was to predict the risk of a 50% decline in eGFR or ESKD. And then we tested multiple different prediction models. One was a clinical model that included just GFR, blood pressure, and proteinuria. And then we developed several full models that included the same clinical variables, but also age, MES scores, prior use of medications. And there's actually two models, one that included ethnicity, which we did because ethnicity was thought to be a very important risk factor for outcome. But because you're not really sure, how to use that in other ethnic groups, we included a model without ethnicity as well. Now, we did look at crescents as a potential predictor, and this comes up, quite frequently, but they actually were not selected as an independent predictor of outcome in this particular analysis. So then we compared model performance between the full models and the clinical models. And it didn't matter how we did that, whether we looked at model fit, whether we looked at C statistics, whether we looked at reclassification, the full models did a better job of predicting the outcome than the clinical models, but there was really no difference between the full model with or without ethnicity. I personally think calibration is a really important metric of a prediction model performance, and that's basically the agreement between predicted and observed risk. So on the x-axis, you have predicted risk that comes out of the model, and on the y-axis, you have observed risk that's actually observed in your cohort. So perfect calibration is given here by that 45-degree line where predicted risk and observed risk are identical. And you can see that these dots fall pretty close to that 45-degree line for both of the full models. So it was well calibrated in the derivation data set. So as I said, we then did an external validation. So this is now done in a separate data set of 1,100 patients. It got very similar model fit, CStat, but also importantly, calibration was well preserved in the external validation data set. Now, since we originally published this paper, multiple other groups have sought to validate it in different ethnic groups. And that's been done in groups from China, Argentina, India, Greece, Korea, and even a group from France extended the follow-up duration out to 15 years and to some extent validated the results. So if you want to use this prediction tool in clinical practice, how do you actually do it? So there's an app called Calculate by QXMD, who we've collaborated with. It's available free of charge. You can download it on your device for free, and you can access the calculator through the app, or you can access it through the online web-based calculator here. Obviously, because it's a survival model, it's not so easy just to generate the predicted risk by hand. So it is helpful to use an app or a mobile or website to do that. Now, what I didn't mention, which may be of interest to you, is that there is a pediatric version of the model, which we have also derived, and that is also available in the app. So if you want to use it in the app, you download it. This is apparently like an iPhone 10 or something super old, but anyways, you could you enter the values of the different predictor variables. You have to select the time horizon over which you would like to predict outcome. Common use would be around 5 years, but not really much more than 7 or 8 years because of the duration of follow-up that was available in the cohort. And then the app will just output the predicted risk over that chosen time horizon. So based on the sum total of this work, the 2021 KDIGO guidelines actually do make a practice statement recommendation that you can use this prediction tool in practice if you want to help risk stratify individual patients. So coming back to our individual patient in our case, we enter her predictor variables into the app, and we get a predicted risk of 14.26%. And then you go, okay, well, that's very interesting, but what does that mean? Is that high? Is that low? I'm not really sure, right? So, and that's a risk over 5 years, but she's only 34 years old. So what I've shown here is the distribution of predicted risk in our analytic data set. And you can see that the most common 5-year risk is around 5 to 10%. That doesn't mean someone's not going to progress over their lifetime, but that's the most common risk in the data set. So 14.2% actually puts her at the higher end of the risk threshold, at least in our data sets. So we consider her to be at higher risk, but first we decide to optimize her supportive care. We increase her ramipril, use some salt restriction and lifestyle modifications. So we're sitting in clinic, and then some astute resident points out, okay, if you look at the KDIGO guidelines on the management of dyslipidemia in CKD, it makes a recommendation that younger patients between 18 and 49 who do not have other cardiovascular risk factors should have their cardiovascular risk estimated using some sort of estimating equation. And if it's greater than 10% over 10 years, you might want to consider statin therapy. So this raises the question, I think, of how do you actually predict cardiovascular risk in patients with IgA nephropathy or with any glomerular disease? Are traditional cardiovascular risk factors sufficient for that purpose? Or do we need to alternatively consider CKD-specific risk factors like their kidney function and like the level of proteinuria? And at least in those patients with nephrotic syndrome, what about the role of higher cholesterol or hypercoagulability? Because I would say maybe management of cardiovascular risk is not exceptionally high on the list of supportive therapies that we might think about in most younger patients with IgA nephropathy. So this raises the question of should we be addressing cardiovascular risk in patients with IgA nephropathy? Well, again, we again working with Mark, we looked at this question in the BCGN registry. So we looked at patients with primary glomerular disease. We looked at a composite cardiovascular outcome, and the 10-year risk of cardiovascular disease overall in the cohort was high, around 15% overall. And it was different by type of GN. So certainly patients with FSGS and membranous nephropathy had the highest risk. But patients with IgA nephropathy and even minimal change disease had 10-year risks of a first cardiovascular event up around 10%. If you looked at recurrent cardiovascular events, the rate was in IgA nephropathy was 12 per 1,000 person years, which actually puts them at a risk higher than 10 per 1,000 person years that is necessary to justify statin therapy. If you compared their risk to the age and sex adjusted risk in the background population, the standardized incident ratio for IgA nephropathy was 1.38. So they were about 38% higher risk than they should have been for their age and sex in the background population. Now, this was not just a problem about progression to end-stage kidney disease. So the rate of cardiovascular events was high even in the pre-ESKD period. Now, obviously, it goes up after end-stage kidney disease. I think we would all expect that. But the point is their risk of cardiovascular disease was high even during earlier stages of CKD. So what about cardiovascular risk factors? Well, certainly traditional cardiovascular risk factors, which we've listed here, were associated with cardiovascular risk. I think we would expect that. But when we added other variables that were associated with cardiovascular risk in our data set, specifically the type of glomerular disease, proteinuria was associated with cardiovascular risk. Each doubling of proteinuria had a hazard ratio of 1.2, as well as declining GFR. It appeared that you could do a better job of predicting cardiovascular risk, at least within this data set, with an improvement in C-statistic, model fit, and reclassification. Now, what was interesting about proteinuria and GFR, I'm not sure what this is here. Okay, well, the GFR figure, for unclear reasons, got totally changed, but that is not the GFR figure, and that is not the proteinuria figure. Interesting. I don't know what happened to the drop to the iCloud upload got changed. Anyways, I'll wave with my hands. The risk of cardiovascular disease increased with levels of proteinuria between 1 and 3.5 grams per day. So it wasn't the case that you had to have nephrotic range proteinuria before this risk increase, right? So patients with subnephrotic proteinuria had a significant increase in cardiovascular risk. And in terms of GFR, the risk increased with GFR levels between 60 and 90. So again, it was just moderate declines in GFR were associated with increased cardiovascular risk in a cohort with primary glomerular disease. So what this suggests is that all types of GN are at high absolute risk of cardiovascular disease, and this is true both before and after ESKD. It seems that increasing proteinuria, declining GFR, and type of glomerular disease may help improve cardiovascular risk stratification. And so when we're thinking about cardiovascular risk factors, there's probably this Venn diagram of overlapping risk factors. Some of the traditional risk factors might stand on their own. Some of them are probably negatively impacted by the presence of the underlying glomerular disease, such as hypertension and dyslipidemia. But some risk factors maybe need to be considered in addition to traditional factors like GFR, proteinuria, et cetera. But this is just sort of demonstrating an overall group effect. The question is, do individual cardiovascular risk formulas work in patients with GN? I don't think we know the answer to that. Or can we improve upon those risk formulas if we add in proteinuria and GFR type of glomerular disease? And probably the big question is, what's the role of immunosuppression in this? Is it the underlying disease, or is it the treatment we're using to address that disease that's driving cardiovascular risk? So these, as of yet, are unknown questions. So if we come back to the case presentation, we evaluate her cardiovascular risk. We get a cholesterol. We estimate her cardiovascular risk using the Framingham risk score, which comes out at 2.8% over 10 years. Now, this is obviously, we recognize, going to be an underestimate of her cardiovascular risk. I'm always skeptical of my own research results. So I'm like, well, it's interesting that we showed this at the cohort level, but again, I'm not really sure how to apply it at the individual level. She's pretty young to start a statin therapy. So I chose not to apply my own research results and decide, well, let's just still focus on lifestyle factors, and we'll see if we can reduce your risk profile through exercise and reduction of cholesterol that way. We also augment supportive therapy, as I mentioned, in terms of increasing ramipril, because she was on submaximal dose. So 1 year later, her blood pressure is now better. It's 120/75. Her proteinuria is 1.9 grams per day, down from 2.5, and her GFR has gone from 75 down to 70, which might be a little bit of disease and a little bit of increasing ramipril. So now the question is, she's 1 year later after biopsy, how do we reevaluate her risk at this point? And so is there a way that we can reevaluate risk in IgA nephropathy over time? The original prediction tool was designed to be used back here at the time of biopsy. If you apply KDIGO guidelines, you may be looking to optimize supportive therapy in the first couple of years, or in the higher risk patients, you may be even wanting to consider immunosuppression early on. And then the question becomes, can we use this prediction tool 1 or 2 years after biopsy to reevaluate risk? So we went back to the International IgA Nephropathy Network cohort and we evaluated this question. So on the left, we have the results of what happens if you use the original prediction tool. You don't change it at all. You just go ahead and try and use it 1 year after biopsy. You get what looks like superficially to be a good C statistic, but I would argue calibration, is not performing very well. There's systematic under-prediction of risk. This calibration curve is deviating more substantially from that ideal calibration at 45 degrees. So it seems like you can't really use the original model 1 year after biopsy. So we went through a model updating process. And once we tweaked the model and updated it, you got the results here on the right. So now we have now substantially improved calibration of the model. We've also improved the C statistic, but more importantly, the weighted difference between predicted and observed risk is now substantially improved. We then applied that 1 year model in an external validation cohort. It applied well in an external validation cohort. And then we also, interestingly, took the 1 year model, didn't change it one bit, and just applied it at 2 years. And it also performed very well 2 years post-biopsy. So it seems like there's this new version of the model that you can now use 1 year or 2 years post-biopsy to reevaluate risk. And again, this version of the model is also available free of charge through the Calculate app. And it's currently under review, but will hopefully be published soon. There's a pediatric version of this 1 year updated model that will be available for use as well. So coming back to the case presentation, so we repeat her risk stratification. So she's now 35 years old. Her blood pressure is better. Her proteinuria is better, but still at a high level. Her histology obviously hasn't changed. And her predicted 5-year risk of 50% decline is now increased. It's now 24%. So why is it higher? Well, we've compared the effects of these predictors in the different models, and it's probably largely driven by the fact that her proteinuria is now sustained after 1 year of observation at a high level. It is better, but sustained proteinuria is an even worse predictor of outcome than one level of proteinuria at the time of biopsy. So she's now at quite high risk of disease progression. So we decided to treat her with reduced dose prednisone according to the testing trial. So why did we make that decision? We made that decision because she was at high risk of progression. And we also thought that she had some elements on her biopsy that we think may respond to immunosuppression because they reflect active disease in the form of endocapillary hypercellularity. She had a few small crescents, and she also had mesangial hypercellularity. So we don't know which factors actually predict treatment response, but nonetheless, we think these may be treatment responsive elements. So you start prednisone, and then you say, well, I'm also going to start calcium and vitamin D. I'm going to start pantoprazole for gastritis prophylaxis, and I'm going to start Ceftra for PCP prophylaxis. This raises the question, though, are there any other infections we should be concerned about other than just PCP? We spend a lot of time worrying about PCP prevention, but what about other infections? So what's the infection risk when you treat patients with immunosuppression? If you look at the testing trial data, these are the serious adverse events taken from the testing trial. So I've split it up here under full dose versus reduced dose, and infection-causing hospitalization was a pretty major concern in the full dose protocol. And that included opportunistic infections. There was an episode of cryptococcal infection in that group. Now, this was reduced quite substantially in the reduced dose cohort, but it still, I think, underscores the importance of thinking about opportunistic infections in patients that are treated with corticosteroids. So I started to think about the risk of latent TB reactivation in glomerular disease, because there's a lot of overlapping risk factors in this area, right? Immunosuppression use is commonly used in patients with GN, and we know that's associated with TB reactivation. We know that autoimmune diseases in general are thought to be associated with immune dysregulation, which can increase the risk of TB reactivation. Glomerular disease also happens to be quite common in ethnic groups that come from endemic regions of the world that have a high background incidence of TB. And at least advanced CKD, like stage 5 or on dialysis, is associated with TB reactivation risk, which is probably one of the reasons you might screen for TB in your dialysis patient population. So again, I worked with Mark to look at this question in the GN registry, and our primary outcome here was active TB disease, which we ascertained based on medication data. But these are medications used to treat active TB, but we validated that case definition against a provincial TB registry. So this is the incidence of active TB in patients with glomerular disease. So first we need a reference. So what is considered high incidence of TB? It turns out the WHO defines a high incidence country as one that has an incident rate above 30 per 100,000 person years. It also turns out that treating latent TB infections in populations with an incident rate above that is associated with an improvement in quality of life. So 30 per 100,000 person years becomes a nice little threshold you can use to kind of define patient populations that are at high incidence of TB. So this shows the incidence of TB in patients with glomerular disease, not on immunosuppression versus on immunosuppression. So obviously immunosuppression increases that risk with a hazard ratio of just over 2. But the incidence of TB was high even amongst patients who were not treated with immunosuppression, or at least during person time not treated with immunosuppression. This was also, as I said, we know TB risk is higher in patients on dialysis, but the risk of TB was high even in the pre-dialysis period. We mentioned ethnicity and immigration patterns, right? So certainly TB was higher in patients that came from medium or high incidence countries, but the absolute risk was still high in Canadian-born individuals with glomerular disease.
Sorry, for reference, what would be the population incidence of BC overall?
Oh, it's well below 30. Like well below 30, yeah. So I'm actually not a TB researcher. Obviously, we did this in collaboration with a TB researcher. When we first got these incident rates, we were sitting them looking at them going, I don't know what this means. And then we showed it to the TB colleague, and he's like, are you sure this is right, that this is maybe it's per 10,000 person or per million? You know, like what is going on here? Like this is really, really, really high. Are you sure it's per 100,000 person year? Like, and it was. And so, you know, his comment was these are very, very high incidence of TB. Now there are subgroups in BC that are at high risk, like our downtown east side population, for example, gets close to that 30, but the overall population of BC is quite low. And that would probably be true in Ontario as well. Now, what about immunosuppression? So time from immunosuppression to TB was extremely variable. So roughly 10% of cases occurred within the first 6 months of immunosuppression, meaning if you waited to treat for latent TB infection to the time you start immunosuppression, you probably were going to miss the opportunity to prevent those cases. But some of the cases were extremely delayed, you know, and occurred years later. So what was the actual incidence of TB in patients with IgA nephropathy? It was 110 per 100,000 person years, which is 13 times the background population in BC. Also, in terms of kidney disease, the incident rate was quite high in patients with relatively modest declines in GFR at around 18 times the background population, the adjusted background population in British Columbia. And again, if you look at risk factors for TB disease, being born in a medium or high incidence country does increase your risk. But again, even those born in Canada were at a high absolute risk of TB disease. There was something about lupus nephritis that was associated with a disproportionately higher risk of TB disease, but the other glomerular diseases were not particularly different from each other. Proteinuria, interestingly, was associated with an increased risk, and that risk increased up to with each sequential increase in proteinuria, but it tended to plateau at a proteinuria value of around 11 grams per day. So and that's obviously very, very high, right? So you sort of maxed out your risk once you hit 11 grams. The absolute risk in patients with GFR, with declining GFR, did increase. That's sort of expected based on previous literature, but it was high even in patients, as I said, with GFRs above 60, or even those with what would be more modest CKD in the TB literature, at least. So in summary, patients with all types of glomerular disease are at a high absolute risk of TB. And this is irrespective of kidney function, it's irrespective of use of immunosuppression, and importantly, it's irrespective of country of origin. So it suggests to some degree that we should probably be screening all patients with glomerular disease much, much earlier at the time of GN diagnosis, that we certainly should not be basing this based on demographics, which is interesting because that's traditionally what we've done, at least in BC. We should not wait until we're wanting to consider immunosuppression because the risk is high even in patients who are not treated with immunosuppression, and you may miss the opportunity to prevent early TB disease that occurs within the first 6 months or so, starting immunosuppression. Okay, so we refer her for TB screening. Fortunately, it's negative. We treat her with reduced dose prednisone. I'm not going to go over the controversies of that today, although we can certainly discuss it if you like. But her proteinuria decreases from 1.9 down to 0.5 grams per day. Her GFR improves slightly up to 75, but she does have some side effects, right? She gets some weight gain, some moon phases, insomnia, irritability. I think no one goes through what's called a reduced dose of prednisone without some degree of side effects. And now we need to make some assumptions. And we need to assume that this residual level of proteinuria that she has, maybe it's due to the little bit of scarring that she had on her biopsy. We hope that it's not due to residual active disease that is left untreated, although we wouldn't know that without a repeat biopsy. And we also wonder, we reduced her proteinuria, but was this worth the side effects of prednisone? And so you wonder, well, is proteinuria lower, but have we actually improved the long-term kidney prognosis in this patient? So this question was addressed by the Kidney Health Initiative, which was a collaboration between the ASN and the FDA. And they did an individual patient-level meta-analysis. So this is 830 patients from 11 different randomized trials in IgA nephropathy, and there was a variety of different interventions that were given at this time. So this included corticosteroids, non-steroid immunosuppression, RAS blockade, and fish oil. And the goal here was to determine if the effect that a treatment has on short-term changes in proteinuria, roughly over 9 months, was a good surrogate marker for the effect that treatment might have on a longer-term validated clinical endpoint, which was in this case doubling of serum creatinine or end-stage kidney disease. So they did a variety of analyses, but this is the sort of their trial level analysis. So on the x-axis, you have the effect that the treatment had on proteinuria in each individual trial. In each individual trial, and on the y-axis you have the effect that same treatment has on the hard endpoint, which was doubling creatinine or ESKD. And the unit of analysis here was the individual trials, and you can see that there's a strong correlation between a reduction in proteinuria over around 9 months and a reduction in the hard clinical endpoint. So this was one of the sort of sentinel analyses that really kickstarted the idea of using proteinuria as a valid surrogate outcome in clinical practice, but also in clinical trials. And so the conclusion of the KHI is that there was epidemiologic, but also now clinical trial data to support proteinuria as a reasonably likely surrogate marker in IgA nephropathy. There were multiple issues, however, to consider. First, the definition of a complete remission in IgA nephropathy is not well defined, right? So we don't necessarily have a specific threshold to define remission. And instead, they suggested, at least on the clinical trial basis, to use reduction in proteinuria on a continuous scale. But what was also not clear is what's the minimum duration of proteinuria that you need to be in remission before that benefit can be seen? Is it just one measurement that goes down, or is there a minimum period of time that you need to be in remission before a benefit is seen in terms of long-term kidney function decline? So again, I worked with Mark to answer that question. So we went back to the IgA nephropathy database. We defined remission as written here. So we identified patients all of whom had proteinuria above 1 gram per day and all of whom went into remission based on this definition. And then our goal here, our main exposure was the duration of remission. And our goal here was to determine, is there a relationship between the time spent in proteinuria remission and the reduction in risk of a 50% decline in GFR or ESKD? So as it turns out, there was really no minimum period of proteinuria remission. So on the x-axis here, we have progressively long periods of duration of remission. And on the y-axis, we have the reduction in risk of the hard endpoint. And each 3 months in remission was associated with a sequentially, better benefit of reducing the outcome. And that occurred sequentially up to durations of a remission of around 3 or 4 years. And once you hit remissions of that duration, you sort of maxed out the benefit and it plateaued thereafter. So there was no minimum period of remission duration. The longer you can stay in remission, the better, which I think is pretty intuitive, but up to that point had not really been demonstrated. What was also nice to see is that the benefit of remission was consistent within all the different subgroups we looked at. So it didn't matter how long it took you from biopsy to get into remission. It didn't matter what the peak proteinuria was prior to remission, or whether that remission was achieved using immunosuppression or using RAS blockade in this particular data set, or based on the underlying MESC histology scores. The relationship of the duration of remission with a reduction in risk of the primary endpoint there was maintained. So the collective literature suggests that the effects of treatment on proteinuria can predict long-term benefit. The KHI meta-analysis suggests that the amount of proteinuria is important, and then our analysis suggests that the duration of proteinuria remission is important. So you probably need to consider both of these independently because they can both independently affect long-term kidney outcome. It does support the concept of proteinuria as a surrogate outcome in clinical trials, and it suggests that short-term changes in proteinuria can likely that results from treatment can likely be used dynamically in clinical practice to reevaluate, the effect you've had and the benefit that you may expect to occur on long-term kidney outcomes. So I hope that I've showed you in these 40 minutes the benefit of real-world population-level data in glomerular disease and sort of some of the outcomes that you can study. But working with Mark was not my only collaboration with Ottawa. I've been friends with Ted for quite some time. We've been going on ski trips every year for quite a while. We've gone to Revelstoke a few times, and this is a picture of a boot pack at the top of the Stoke chair at Revelstoke. You can hike up into the high alpine, and it's about a 30-minute hike. And unfortunately, all the guys we ski with are always too lazy to do it. But Ted's the one guy I know I can pick off from the rest of the group and force him to go do some interesting stuff. So this is a picture of us at the ski out more at the bottom at Revelstoke a few years ago. So I'd like to thank you for your attention. I'm more than happy to take questions or discuss, anything that you want to talk about in glomerular disease, really. And I'd like to thank my collaborators and source of funding. Yeah. Okay. Give me 1 sec. And sure. Yeah. All right. And then and sharing.
Yeah.
Right.
Yeah.
Okay. Okay. Go ahead, Greg.
All right, thanks, Sean. That was a really good talk. Sorry, and I missed the first sort of 5 minutes, so maybe you went over this, but in your prediction model, and I'm assuming there is like hundreds of these done in the past, what made yours perform so much better? What were the key variables you think that are driving? Like it's a very, from a statistic and calibration point of view, very good model compared to lots of stuff I've seen, for example, in transplantation. So what are there some key driving variables in that model?
I think, so we were by no means the first group to ever look at a prediction model in IgA nephropathy. This had been done many times before. I think some of the major limitations were that the use of single center data sets that were just too small for a purpose, and the use of histology classifications that hadn't really been on their own validated. So the strength we had is that the MES score and then the MES-C score was derived originally in 2009. And it was derived for the purposes, instead of a bunch of pathologists sitting around saying, how should we classify lesions that we think group together? It was derived for the purpose of identifying lesions that were associated with outcomes. So it was a histologic classification that was designed initially to be associated with outcome and then had been shown to be reproducible across pathologists. So they only pick lesions in the MES-C score that actually have a reasonable agreement between pathologists. This is different than, for example, the Lee or the Haas classifications before that were sort of lumping systems that group them together, and it'd be sometimes confusing as to what patients should go into which class. And the second thing was the diversity of the data set. So this was a large collaborative endeavor. It wasn't a single center. This was a bunch of people from China and Japan and Europe and North America, South America, all of whom decided it was time to really work together to merge data sets instead of trying to do work on their own. So I don't think there was anything fancy about there was nothing fancy about the actual predictors in the model. It was just the data sets that were available to do it in were far more diverse. And when you have that level of diversity, I think that's what really strengthens the external validation of the tool is that you derived it in the first place in a relatively diverse patient population. So I think that's probably some of the benefit. And since that time, people have tried to use machine learning or other newer modeling techniques. But again, when you do that on single center, smaller data sets, you end up with a substantial risk of overfitting, which then is why there's compromise when you go to externally validate the results.
And Mark, does our local pathologist, do they report the MES score? I haven't seen an IgA biopsy in a while.
Oh yeah, it'll be on all IgA nephropathy biopsies. I guess in some situations, if it's a very atypical biopsy, like an IgA dominant, but it looks more like maybe a parainfectious, or there's maybe a light chain or something. Sometimes they might not necessarily report the mess because they believe there's something else driving it. And then, we discuss with them, okay, well, if this was IgA, what would we be looking at? Because we do consider that for treatment.
The other time your pathologist may not report it is if there's fewer than 8 glomeruli in the biopsy sample, because technically you needed a sufficient sample to give the classification. So, you do need a sufficient biopsy to also give it.
Thank you.
Thanks, Greg. Ayub.
Thank you, Mark. Thank you, Sean, for an excellent talk. I noticed that your calculator has grams per day of proteinuria. So are you doing 24-hour urine on patients, or you do urine albumin to creatinine ratio and protein to creatinine ratio?
This is a trap, Sean.
This is a trap, yeah. I feel like I'm being switched here. So that's okay. I'm going to walk right into it. I would argue if you want to risk stratify somebody with IgA nephropathy, if you want to risk stratify somebody with membranous nephropathy and you want to know, do they have 5 grams or do they have 3.5 grams of protein, you cannot ascertain that information from a spot urine ACR or spot UPCR result. That's been shown quite readily from the Neptune data in the States, where the relationship between UPCR and 24-hour urine was extremely variable. That's also been shown in much larger studies looking at urine ACR, where the variability is very, very high, especially at higher levels of urine ACR. So the purpose of those tests were more as screening tools, to identify people with proteinuria. But if you actually need to know what the value is, you cannot ascertain that off a spot sample. You could potentially consider it off of a 24-hour urine sample, which is what's being done in clinical trials in order to mitigate the limitations around, up and down collection completion. So if a patient doesn't fully complete the full 24 hours, they might miss a sample. A UPCR done on a 24 hours aliquot it might be more accurate, but of course that doesn't mitigate the problem of having to collect a 24-hour urine, sample. So if you need to know what that result is, you probably need to measure a urine PCR. And if you're making treatment decisions based on an ACR or PCR and spot test, you're probably substantially, misestimating their 24-hour protein excretion. That being said, I don't think you need to measure them all the time, right? Like, measure it when you think it will actually change what you do and when you need to actually assess a treatment response. If you do have, at least within the individual patient, some degree of repeated measures over time, you'll understand what their creatinine excretion should be, and then you can catch under or over collected samples relatively easily. But the summary of your question is that in the prediction tool, you do need to use 24-hour urine collections. Now, a caveat to that is the pediatric tool. So it's very, very hard to get 24-hour urine collections in children. So in children, we did not. You can use the ACR and PCR in that situation, but that's because children is, I've never treated a child, but I would imagine with my own kids, it'd be virtually impossible to get them to do a 24-hour urine collection.
Thank you. Thank you, Sean.
To do anything. Yeah.
I'm saying children and teenagers.
Sean, sorry, I had another question. Have you looked at your data with eGFR less than 45 and compared it to kidney failure risk equation?
Yeah, the comparison to the kidney failure, we haven't done that, but that has been done by other groups. And the kidney failure risk equation overall, in the overall group of IgA nephropathy, does not predict outcome as well as other prediction tools. And they did, I don't remember where this was published, but I remember reviewing the paper that they did make this comparison. But I think once you get down to advanced CKD and a GFR less than 45 or less than 30, like, you don't need a prediction tool to tell you that person's going to progress, right? They're going to progress. And so the KFRE probably becomes sequentially more important the more advanced CKD you get. But the vast majority of patients that you're dealing with are probably at the higher GFR range that you're trying to risk stratify, because that's where you have the opportunity to make treatment decisions that might actually alter their trajectory, at least in terms of immunosuppression. So that has been looked at. I don't remember if they did it only in low GFR, but in the overall patient population, including those with higher GFR, didn't work quite as well. But it wasn't designed for that purpose, right? It was designed for CKD risk stratification, and so I wouldn't say that's a failure of the KFRE. I would just say it was meant for a different patient population.
Yeah, and in your prediction, KFRE has just progression to dialysis. Your prediction model has 50% reduction in EGFR2. So it's a different model.
Yeah, it's a different outcome, and we did correlate the predicted risk of a 50% decline in GFR with the rate of kidney function decline. We have some additional data which we haven't published yet that tries to refine that correlation because most trials now are using rates of kidney function decline, not time to events, because it's a more effective way to design your study. But it does correlate quite well with the rate of function decline. So if you're at a higher risk in the higher risk group, your rate of kidney function decline increases up to about 5 mLs per minute per year. Whereas if you're in the low risk group, it's sort of hovering around 1. So, and that difference becomes quite significant when you extrapolate it, obviously, over the lifetime of a patient.
Okay, thank you, Ayub. David, I really hope you're not also falling into the trap, because you and Ayub already discussed this for about 8 hours on the way to Philadelphia.
No, this has nothing to do with what Ayub said. Thanks so much, Sean, for the presentation. I'm sorry I couldn't be there. I'm on the road to dialysis rounds. I had a question regarding your reassessment of risk of progression or risk in IgA at that 1 year mark. Do you take into account their change in GFR from the time of biopsy to that next time point? And the reason I ask is because I find that, anyways, in our patients, we often see some patients that have significant proteinuria and they're put on conservative therapies and they still have significant proteinuria 1 to 2 years later, but their creatinine has not changed, sometimes for even many years, 2, 3, 4 years or more. So is that something that is considered, and what's your personal opinion about that?
Yeah, well, thanks, David. I'm glad you decided to drive and not run the 100 kilometers to your dialysis unit, so you could ask this question. But the model does take into account the GFR at 1 or 2 years. We did look at change in GFR, but there wasn't enough change in GFR in the cohort, as you said, to really make much for that to be different than just using the absolute GFR value at 1 year. So it does include eGFR at 1 year. However, what's interesting is that if GFR is stable over that time frame, the risk of disease progression associated with that GFR becomes less. So I think this is because it's a 1 or 2 year update. We don't know if that will work if you try to use it 4 or 5 years after biopsy. That hasn't been looked at. And maybe other groups who have longer follow-up, could potentially look at that issue, in which would be a time frame over which you might see larger changes in GFR that may prove to be important. But I think that my personal opinion on the matter is that I don't want to wait and make treatment decisions until GFR declines, because for the most part, that becomes too late. Like, the average story for IgA nephropathy is much like I presented, which is that someone has had some degree of hypotension or hematuria for quite some time. Their IgA nephropathy probably did not start when the biopsy was done. It started 10 or 15 years before that. And so someone who is young and 34 presents with some degree of scarring already. So if you already wait until their kidney function declines, if you do repeat biopsies, you'll see the burden of scarring is increased dramatically, and that's when the benefit of treatment becomes sequentially less. So the goal here is to prevent dialysis over their lifetime. So another point is the prediction tool might predict a 5-year risk because that's what was available in the cohort, but a 34-year-old person doesn't care about a 5-year risk. They care about their lifetime risk, which is obviously going to be much, much higher. So I think that we have to use things other than changes in GFR, because the change in GFR doesn't, in the time frame in which you want to make treatment decisions, it's not going to change that much. And if it is changing that much, then that patient has a bit of an issue.
And so just to follow up to that, another reason for like my point was, when you look at the trials, a lot of times, the patients in the placebo or the control group have quite a dramatic decline in GFR on a yearly basis. I don't remember the exact numbers, but in my mind, it's something like 5-6 mLs per minute. And that's where, because I believe a lot of people are using these risk predictions to rightly or wrongly guide treatment decisions on whether they're going to give immunosuppression or any other immunomodulating therapy. And so those patients that in the trials demonstrate such in my mind, dramatic declines in GFR, those are probably the ones that have demonstrated to have benefit. And so, if you're looking at a patient that have a high risk, but their creatinine stable, I'm not sure I should be using that to guide my my treatment decisions. And I know you didn't really go into treatment choices, but I don't know. Am I wrong to think that way? Should we be looking at it another way?
Yeah. So the rate of I guess I'll try to dissect that down a little bit. So the rate of kidney function decline in the different trials is quite variable. So the testing trial had an exceptionally fast rate of decline in the placebo group of around 5 or 6 mLs per minute. That was a very high risk patient population. Their time from biopsy to study entry was very, very short. They had a lot of activity on their biopsies. So they were a high risk patient population. So that much is true. The rate of kidney function decline is different in other studies. For example, in the NephroGuard study, the rate of function decline in the placebo group was high, but somewhat more modest. If I remember correctly, it was somewhere around 3 or 4, which is still high, don't get me wrong. But in the sparsentan trial, for example, it was much lower in the placebo group, right? And the sparsentan, authors would say, well, that's because we optimized, supportive therapy in the supportive in the control group so well, and that would be maybe one explanation. The other explanation is just a different patient population that was given a different drug that has a slower rate of decline. And so I think what can be said is that the relative risk estimates of treatment effects in most trials and most treatments are relatively preserved across the spectrum of different diseases. And so, relative risk estimates can be somewhat important, but if you then apply that relative risk estimate to a very low risk patient population, the absolute benefit becomes much lower. And so I think you need to weigh that absolute benefit against the actual absolute risk of the drug, right? And so you need to decide which patient population you want to give these drugs to. It is absolutely true that the prediction tool should not be used on its own to make treatment decisions. It was not designed for that purpose. If the purpose is to identify patients at risk of progression, that is what it can be used for. You need to then decide, if you apply a relative risk estimate to it from a trial to a patient population of that risk, do you think the risks of the drug are worth the benefits? And that's something that, for example, even reduced dose prednisone has a moderate risk of side effects. For that matter, so does NephroGuard. Nefecon has some steroid related risks. I think we've also seen in these trials that have longer follow-up period that even when you treat for a short period of time, there's probably some patients that have disease relapses later, and you have to be willing to repeat treatments over time. And that's probably not something we want to do with even reduced dose prednisone, right? So what we probably need are more tolerable therapies that can be given, sequentially over time or in different treatment groups. So, I think you have to kind of weigh the risk benefit on an individual patient basis, obviously, but you shouldn't, strictly speaking, be just using some cutoff to say this person's at high risk from the prediction tool, therefore I should treat them. What drives a lot of risk from the prediction tool is T2, right? A T2 score in a biopsy really increases your risk of progression, which is like a very high burden of scarring and tubulointerstitial fibrosis. And that is probably not someone, like that element of the biopsy is probably not going to get better on prednisone. That might be someone who made you better on an SGLT2 inhibitor, for example, addressing the hyperfiltration aspect of and augmenting their supportive therapy. So the prediction tool can't identify people who will or will not respond to treatment.
Okay. Yeah, totally agree. Thanks so much, Sean.
Thanks, David. We have time for one more quick question. I think, Todd, did I see you had your hand up?
I do. I don't know if I should defer to Kevin since I'm meeting later with Sean.
Go ahead, Todd, unless it's,
Okay.
Well, let's see what it is first.
All right.
If it's existential,
well, I
not.
guess I'm very struck by and perhaps scared by your high rates of TB that you're seeing in your study there. I guess my clinical experience has been that I haven't seen quite as much TB. And I might have missed this, but can you remind me what population you were looking at, like what cohort you were looking at when you were looking at those TB rates? And I guess some follow-ups to that would be, does this correlate with other forms of immunosuppression? So is this extreme TB risk also seen, for example, in the transplant populations, or is it unique maybe to your population, and that, you know, you have 1 or 2 extra TB cases and that's really going to change your risks overall?
Yeah, I mean, the absolute risks here are still low, right? I mean, active TB is not something that we think of should occur in our society really much, you know, at all. So I agree with you. It's not something that comes top of mind because it's such a rare outcome. And that's probably why clinically we don't think about it too much. And to be honest with you, I struggle to even apply the results in practice because I'm not sure what your process of care here is for referring for TB screening, but you know, we have to refer to the BC CDC for screening. It takes, you know, considerable time and effort. And I would say I still have struggled to move to more broad TB screening in everybody. And, you know, I have talked to our colleague about trying to actually study and implement this to make it easier. Certainly risks of TB are higher in transplant populations. They do quantiferin assays, you know, in patients pre-TB. It's higher in hemo patients, as I said. Which is why we screen all of our hemo patients for TB. But the patient population we looked at were patients with primary FSGS, IgA, minimal change, or membranous nephropathy in the province of BC. So this was not a common outcome. It was a rare outcome, but it's a rare outcome that occurred far more commonly than it should compared to the background population. You know, roughly 13 to 14 times more common than it should. And I think that's why it's hard to deal with clinically, is that it is still a rare outcome even amongst our glomerular disease patients, but it's logistically challenging to actually implement, I would find, the routine screening and treatment. I don't know what your experience is here in terms of screening TB for TB, whether you do it yourself or you refer to a CDC.
Yeah, good question. Part of it depends on how you're testing. So to do you know, TB testing, many family doctors will do it. We are hoping to implement TB skin testing in our GN clinic. But I would say standard of care, like if you're going for a transplant, 100% you have TB testing done pre-transplant. In the GN clinic, as you mentioned, part of it is logistics and overall risk. So, you know, patients that are coming from TB endemic countries, maybe weren't born in Canada, or from you know, TB endemic areas within Canada, we're definitely screening for. People that are younger, have grown up in the city in Canada, we are not routinely testing before immunosuppression. So
yeah, and I would say we do the same thing, but unfortunately our data doesn't really support that, right? Because unfortunately people born in Canada were at high risk, and high enough risk to justify latent TB infection screening and treatment, right, as well as time periods not on immunosuppression. So, you know, in some way, I think we do need to move towards more broad screening, but I think we need to collaborate with our local CDCs in order to try to implement that. It's not really feasible to do it at an individual physician level for all patients.
Okay, thank you, Todd. I'm trying to see, I don't see any more hands there. It's after 9, so I think we'll wrap it up. But Sean is here for pretty much the whole day. We're squeezing every last drop out of him. So he's going to meet some of our colleagues in the morning. He'll be at, he's actually meeting you at the General, Todd, a bit later. He's back in the afternoon to meet with the fellows. So there's lots of opportunity to pick his brain. So thank you, Sean. Thanks everyone for participating. Have a good day.